Complications of acute anterior urethritis. Abscess of the urethral glands. Minute abscesses due to obstruction of the ducts of suppurating glands doubtless occur and pass unnoticed amidst the intense symptoms of every acute urethral gonorrhea. Such abscesses occurring during the declining stage cause a characteristic brief explosion of acute symptoms. After a day or more of vague, localized uneasiness or itching, a sharp reinfection of the urethra occurs. The discharge becomes profuse and creamy. The meatus may even swell, but there is usually no pain. But no sooner has the patient decided that he must look forward to weeks more of suffering than the discharge abates almost as suddenly as it appeared. This sudden abatement of discharge is doubtless due to local immunity persisting from the preceding acute urethritis. It is exceptional for this immunity to be so slight as to permit prolonged relapse. Periurethritis and periurethral abscess. Extension of suppuration from an infected urethral gland to the periurethral connective tissue is to be expected only as a result of overtreatment or of scars left by antecedent gonorrheas. The suppuration arises from the balanitic, the pendulous, or the bulboperineal portions of the anterior urethra. Abscesses arising from the balanitic portion of the canal appear at one or both sides of the preputial frenum. They grow rapidly and, having opened or been incised, often leave permanent fistulae requiring a special procedure for their cure. Abscess of the pendulous urethra usually projects from the floor of the canal as a hard nodule. It may grow quite slowly and may resolve or break into the urethra, but it is far more likely to invade the skin and point directly opposite to its point of origin, or to travel beneath the fascia for a considerable distance before discharging externally, unless its course is cut short by incision. The fistula heals spontaneously. Abscess of the perineal urethra is usually spoken of as abscess of Cowper's gland, though it is impossible to say in what proportion of cases this gland is actually the one involved. The inflammatory mass often appears to one side of the median line and usually travels to a distance beneath the deep fascia before breaking through this, thus causing extensive perineal infiltration, if not promptly incised. All of these processes travel forward so that, while abscess originating in the pendulous urethra never points in the perineum, perineal abscess may show itself prominently only about the pendulous urethra. The attachment of the deep fascia to the anterior layer of the triangular ligament prevents extension of perineal suppuration backward. Inflammation of the erectile tissues. Spongiitis and cavernitis are extremely rare complications of gonorrhea, if we accept that type of the former that manifests itself in Core D. Thrombophlebitis of the erectile tissues or inflammation of the fibrous envelopes manifest themselves as sensitive indurations of the erectile bodies. Under appropriate treatment, they usually resolve, but they may suppurate and require incision. Balanopostitis. The gonorrheic with a long or tight foreskin usually develops balanopostitis in spite of all his care. Yet the complication is rarely severe. It has no peculiar characteristics, is apparently due to mixed infection, and readily yields to the usual treatment. Lymphangitis and Lymphadenitis. These complications are rare, inasmuch as they are due to extension of the gonorrhea beyond the urethra proper. They result usually from balanitis, less often from periurethritis, and, like the balanitis of gonorrhea, are not specific and are rarely severe. I have seen but one gonorrheal bubo that required incision.